Hello everyone. My name is Fuad Rahman. I represent University of Arizona and also GoldLeaf.ai. It's an AI company that is using artificial intelligence and machine learning to process healthcare data. Today I'm going to talk about the effect of big data and AI on pandemics and specifically on public health. The title of the talk is Utility in Pandemics and Public Health: Hope versus Hype. We're going to be talking about big data, of course, because that's in the title. But the main focus of this talk is about how do we use big data and artificial intelligence in building health vigilance and population health management tools, and how that actually extends into our current pandemic that we're going through, COVID pandemic. Um, we all know that most of the healthcare data is actually in unstructured format. In some estimates, it's about 80% of that data in unstructured format. We all know also that AI type of systems work really better on structured data, which basically means that 20% of the data is probably being used right now, right? And the rest are not. So that actually is a big issue because that means we are only getting a partial picture. Now, data can come from many sources and can be of many different categories, right? Data can be, and the main issue is that they're all siloed. Because they are siloed, we need to be able to somehow break that silo and that get this data out so that we can actually take a look at a more holistic picture. So, how do we do that? In general, as we go up the chain of abstraction, as per se, that data becomes information, information becomes knowledge, and knowledge becomes something actionable or wisdom. And if we look at the left side of this pyramid, as you can see, the human effort goes lower if we can automate most of this or some part of it. And that's really is the focus of this talk today. How can we use uh, knowledge curation, data curation, to build a system using advanced AI and machine learning that can actually help us reduce the human effort but produce, very good results. Now, what do we really mean by AI-based health vigilance and population health management tools? Let's take a look at, what population surveillance actually means. I mean, obviously, population is based on individual patients. So they come with some complaints, doctors look at that, they make some observations, physical findings, they perform some tests. From that comes diagnosis and a treatment plan, and eventually medication, and the cycle repeats. A lot of this data, obviously, and when you take all these patients, you get a cohort and ultimately a population, of course. But if we look at this next slide, a lot of this data is siloed, right? Um, so how do we free that data out from those silos? And one way of doing that would be if we could tag the data using some sort of a structured semantic tagging taxonomy and background ontology of that. Then we can take the data out of the silos, put them into a level field, and perform analytics on it. And that's exactly what we're trying to do in this particular effort. Uh, and once we actually have tagged data, we can actually now have additional data sources, which is genomics, that we didn't have before. COVID-19 is the first pandemic, as we know, since the human genome has been fully sequenced. That's a very powerful source of data, and that data is very, very useful in large data analytics, especially using artificial intelligence. So the what can we really do once we have these diverse, disparate sets of data coming together? It's a huge data. What we can do is something that we put into this slide. We can take a look at this semantic curation, which basically means take the data, structured and unstructured at the same time, tag it using some sort of a semantics taxonomy. And then out of that data, we can perform analytics and build some models. And maybe we can take a look at what part of the population is susceptible to a particular disease. If they're susceptible, then how what is the degree that they're gonna get affected, right? The degree of actual infections, and what's going to be their outcome, right? What is the rate that we expect to be recovered? What do they expect not to recover? If we're able to actually indicate or at least estimate uh, these populations, then this is a huge advantage, because then we can use that information to kind of preempt before certain things happen. So maybe pay extra attention to specific population sets. That's a huge step forward. The question is, can machine learning and artificial intelligence can be used to do certain things, like I just mentioned. Um, so if we could do that, what would really that mean? That would mean that we can actually constantly take a look at a population, monitor a population, in an almost like an anonymous fashion, and actually can accurately find out how a population is going to be impacted by a specific pandemic, for example. So let's not talk about AI and how that plays out. Uh, I talked about semantic curation before, and I mentioned that we will use some sort of a taxonomy to tag the data. One of them is SNOMED City, that we all know about. RxNorm is another one. Loink is another one. We have used a taxonomy called CSN, which is Clinical Semantic Network, which has about 1.5 million clinical concepts. And it kind of has pretty much everything that SNOMED, RxNorm, and Loink has. Based on that, we actually used artificial intelligence and machine learning and a lot of natural language processing tools to build that into a set of um, artificially modeled AI models, right? And right now we have about 30 of these models, and taken together, this represents the kind of the knowledge that's encapsulated in the CSN. Now, once we have that, how do we use that? So basically, if we look at the top of this figure, we have data coming from different places: EHRs, nodes, claims, and other places. We synthesize them, we tag them in the pre-processing harmonization step, and then we put some sort of a registry that can then go into an analytics source that can do disease modeling, it can do response forecasting, it can do advanced stratification or contact tracing. There's a lot of other applications that can actually happen. Once we have all that stuff, then we can really start doing consumer level or patient level engagements based on that. Let's take a look at an example of what that really means. What we did in this case is that we were looking at a disease which is comparative disease, a disease that is like COVID. And we started this about a year ago when COVID was just starting out. And we were lucky that we have access to influenza data of patients who had influenza. And we know that there's a lot of commonality. So we use that as a foundation disease. And based on that, what we did was we identified that disease, in our case, this is influenza. We identified key aspects of a cohort so that there is enough commonality. We extracted key signals from structured and unstructured data, mainly unstructured data, which is, as you know, 80% of the data. We clinically aggregated all the data from different sources. And then we applied machine learning, the models that we talked about 30 models. And based on that, we tried to do something very simple, which is, can I predict from this, can I learn first from this population, um, what portion or who of these patients would actually develop influenza based on their current or past clinical records. Uh, and that's an interesting first step, because if we can actually predict that this is the population which is vulnerable, then we can preempt that happening, yeah, and maybe take a look at how we can intervene and take better care of this population. Now, what we did was, we're very lucky that we got access to real data from a East Coast healthcare system, and we got about 30,000, about 3,100 patients, and it was completely de-identified, of course. And we artificially made this balance, because we don't want the AI models to be influenced. So based on that, what we did was, we took 85% of the data to train our models and 15% of the data to actually test it. So any testing, any results that I'm going to talk today is based on unseen data, because that 15% that we tested on, the machines never actually have seen. And total number of variables that we extracted are about 110 variables. And based on that, we created different type of combinations of networks. We call them networks because they are coming out of data coming out of different type of sources. So we looked at, for example, problem list, which is a structured source. But then we looked at NLP network, which is basically free format text. We looked at diseases and findings, which is basically purely structured. So we looked at purely structured sources, purely unstructured sources, combination of them, try to find out where we actually can get the best performing models. And as you can take a look at these results, that um, you know we can actually get very high accuracy in predicting the onset of influenza. We haven't gone to the point where we can actually say how sick a person is going to be, but we can accurately predict that this population or this portion of the population, these particular patients are going to develop influenza. As you can see, most of the models are in high 80s, but one of the models is actually in high 90s, which is, as you know, for prediction of this kind of problems, is a very respectable number. Um, so so this is actually what we did on in terms of influenza, because that's the data we had. Right now we actually are again lucky that now we have got access to COVID data, COVID patient data, and we are actually now rerunning those experiments and those modelings, because we want to see if our models are equally successful on predicting COVID patients. So let's take a look at some final thoughts. Um, from what we've been looking at in the last couple of years in terms of this particular effort, it looks like that a holistic view of semantically organized data, tag data, actually are very useful for AI type solutions. We also is seeing that population health, um, actually in terms of health outcomes and risks, can actually be monitored and looked at in terms of these very complicated but very useful models. But most of all, we think that AI can synthesize information about individuals into discrete semantic concepts, again going into the semantic curation concept. And we can, especially with the help of genomics, can actually create a lot of very actionable intelligence that policymakers and clinicians can actually take a look at. And I think at the end of the day, what we can safely say is that deep, well-formed data, tag data that are identified, can actually lead to greater precision in managing populations. Um, and this is only the beginning. I mean, we are just learning how to use AI and machine learning into complicated healthcare data. Once we get a little better over time, we'll be able to predict a lot more than what we can currently do. And hopefully we can do a much better, and we can create a much better response to future pandemics, which we know will come, than what we actually did for COVID-19. So I think that was all I had. Thank you so much.